The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. Welcome back to the Virtual Curbside. This is our monthly episode 4, where we get to ask our speaker all the questions that we've gotten from our episodes for the month so far. And by the way, thanks for all your questions and feedback. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. This is the week where we get to answer questions, and it's really a delight to have Dr. Pat Cartwright back with us this week to deal with some questions that came in based on the episodes of the last couple of weeks. Thank you so much for coming back, Pat.
Thanks for allowing me to come back.
It's a delight. Let's dive right into the questions. Do you have anything you'd like to disclose before we answer questions?
Still no disclosures. It's, as one of my surgical partners said, sponsored by Vicryl.
Excellent. All right, question number 1. This is kind of a long one, so brace yourself. With the increased risk of cancer, even in treated cryptorchidism, is there anything else we should do to protect our patients beyond ongoing surveillance and education after treatment? What's the proposed mechanism for testicular cancer in cryptorchidism? Are there other associated cancers? Is there an age where cancer is most likely to develop? And is that different from the usual pattern in testicular cancer?
Yeah, really good questions. Don't have answers to all those, but let me try to give basic perspective, Paul. So undescended testis is a fairly common thing at birth. 2 to 3% of boys, at least half those descend by the time they're 9 to 12 months of age. We talked about that being a good time to treat them. If you treat testes really early with orchiopexy, some of the most recent data say that you may have a relative risk, lifetime risk of testis cancer that's about 1.5 compared to a controlled or bilaterally descended group. So if you compare that, some of the old studies said orchiopexy anywhere under 10 years of age, which is a huge range, and usually they're being done at 5 to 10 years of age. This is a Swedish study, and that was the norm for about 3 or 4 decades. If it's done before 10 years of age, but probably after 5, it's about a 2.5 relative risk or hazard ratio over time. If it's done over age 10, it's about a 5.5 increased risk. So an interesting thing there, that bringing testes down and putting them in a scrotal position with the best data available, which is hard to get, because the answer to the other part of the question is the real risk range is from the onset of puberty to about age 50. So it's about 15 to 50 if you want to catch virtually all the testis cancer that's going to form in everyone. It's the same in an undescended testis that's been brought down versus a standard male testicular cancer that's formed without a history of cryptorchidism. So the timing's the same, happens puberty till age 50. Most of them are like 25 to 35. That's where the peak is, but it tails out on each end of that. So bringing them down seems to help them, but doesn't bring it down, even if we PEX as best we can tell at 6 months of age, doesn't bring it down to total baseline descended testis risk. Why? And that's a question people are not completely certain of, but there's some interesting things. Almost certainly it's a 2-hit issue. There is a basic, probably endocrine-related cell level issue with undescended testes. And then there's the correct position, which is almost certainly heat-related, with intrascrotal position being probably 3 to 3.5 degrees cooler than the rest of the body, Fahrenheit. So it's probably those two things together that give you the highest risk. An interesting thing is that if you have a cryptorchid testis, whether it's brought down or not, the contralateral testis has about a 3-fold higher risk than a standard bilaterally descended male will have. So the contralateral testis opposite a cryptorchid testis is also at risk. So there's some sort of, in the developing fetus, young child, global cellular endocrine related defect that probably causes non-descent and at the same time sets spermatogonial stem cells, which are thought to be the source of most adult male testis cancers, down a peculiar pathway where later on they take the direction of cancer formation rather than genesis of spermatogonia. So a little long-winded, but it's probably not normal from the beginning. Added to if it keeps a wrong temperature over time. We make them better by bringing them down, but we don't bring them back to baseline.
Fascinating. Okay, so here's a question that has come up that I've never been able to answer. Just a completely, I guess, only partly related question. Is there an increased risk if young men wear particularly supportive undergarments?
No data that supports that.
Okay, now I can answer more definitively.
The two leading risk factors in a male for cancer is history of cryptorchidism or history of a testis cancer in a close family member. Those two things are your two biggest risk factors. I think the other question was about screening and watching for things over time.
Yeah. Yes.
Really, the only truly useful thing is legit monthly self-exam and periodic exam by a physician. I think that most of us would love to see once a year exam by a qualified person in addition to monthly exams by young men, but getting, males age 18 to 28 to come in for an annual testis exam is vanishingly unlikely.
Sometimes it's even difficult to get the males back in who had leukemia, who have a reason for surveillance as well.
Yes. Let me throw one other thing on that, Paul. In the same vein, the issue comes up about testicular microlithiasis. And so, some of the question, if you have testicular microlithiasis, are you at risk for germ cell cancer over time? And that's been pretty definitively shown in a 2,000 person registry that was followed for 20 years. The answer is no, that pediatric microlithiasis in the testis is not an increased long-term risk for adult forming and testis cancer. So ultrasounding and looking for that or following it over time doesn't seem to be useful anyway in predicting who gets it or finding it early. So it's really self-exam, painless, firm mass in the testis that is the key to find them early.
And how does microlithiasis present?
It's usually just an incidental finding.
Gotcha.
It's not palpable. They get it for something else and oh, there it is. So the interest came that adults who have a proven testis cancer tend to have more microlithiasis in the associated testis than in a cohort group that doesn't have any testis cancer. And that's when it came back, oh, maybe it's forming in childhood because we see it occasionally, or those are the patients who are going to get it, and they're unrelated. So the ones in childhood don't seem to be the ones who then develop testis cancer associated with it.
Terrific. Next question. My understanding is that hydrocele is an accumulation of fluid in the tunica vaginalis. This may be a misguided question, but can hydrocele exist in the absence of a testis being present in the scrotum? Should this have an effect on my search for potentially missing testicles if a patient has large hydroceles?
Yeah, no, very good question. So hydrocele is fluid in the tunica vaginalis. So let's do tunica vaginalis 101 just for interest. So in the fetus,
of course, I have this down, but for the other people, maybe.
Just Paul, why don't you go ahead and just present this part?
No, I'll defer to you on this one, Pat.
Okay, thank you so much. Yeah, I had to Google it anyway and look it up again to make sure it's accurate. No, the first thing that forms in the fetus is an outpouching of the peritoneum, which is the processus vaginalis, and the gubernaculum that basically goes down to what will be the scrotal fold and become the scrotum. So those two things form first. And then around that, the inguinal canal forms. And as it forms, the processus vaginalis goes through the inguinal canal, sort of drawn down by the gubernaculum into the upper part of the scrotum. And then the inguinal canal sort of forms around that. So that's the usual. Male and female have a patent processus in utero that usually closes a few weeks before birth to a few weeks after birth. It's dramatically surprising that we don't know that more precisely, but we know that happens. It should happen that way. So if it doesn't close, it remains open from internal ring where it connects the peritoneum all the way down to in the female in the labium or in the male in the scrotum, then it can be one of two things clinically. If it's large enough and intestine pops into it, then it's a pediatric or indirect inguinal hernia. If fluid goes into it, then it's a communicating hydrocele. Now, that same processus vaginalis, if it closed, it never closes the distal aspect. It closes the proximal aspect, but from the external ring down to the testis, that part always remains patent. So there's always a potential space around the testis, and there's always a tiny bit of fluid in it. If something inflames the lining of that non-communicating remaining portion of the processus vaginalis, then you get a non-communicating hydrocele. And those can come up after trauma or a viral infection, and sometimes they'll get bigger. And then the lymphatics around take over once the inflammation's gone and they get smaller again, and you just try to leave those alone. And then the final thing that can occur is a hydrocele of the cord. People will call it an encysted hydrocele or a funicular hydrocele, but basically that's where there's a little bit of fusion proximally and a little bit of fusion distally, but it leaves the mid portion of the processus open, and that collects kind of a cyst of fluid along the spermatic cord. So those are the sort of the different things that you can see. So having said that, going back to your direct question, you definitely can have a patent processus without a testis either having formed on that side or with the testis still being intra-abdominal and the sac being sort of distal to that. So the clinical question that comes up then, you guys see a hydrocele, is the testis down or is it not down? You can feel above the hydrocele if it's small enough. Basically draw the hydrocele distally, feel right at the external ring, and see if you can feel spermatic cord. If you pretty confidently feel spermatic cord there, that it's probably in that hydrocele, but the hydrocele is just too big for you to palpate the testis. You can also use a light, shine through the hydrocele. This is a little more dicey, right? And see if you can find a place where it looks like there's a non-transilluminating testis. And that can be done, but it's a little harder. And then you can ultrasound and look for the testis. I would say, practical suggestion, if there's a hydrocele that you're worried about, that it's changing sizes day to day, or it's persisted past age 18 months, send to us for evaluation without an ultrasound, and let us work with you on determining which ones need it and don't after we examine and check. Sometimes we can sort it out. I mean, again, have to be good at something, and finding testicles is one of the things we get better at as we do it for a few years. So that's probably the direction I would take that. I think it's a good question, and you can definitely have it without. You can also have a patent processus and a communicating hydrocele or hernia in a female, obviously where there was no testis involved there at all. When the processus doesn't fuse in a female, there's a couple interesting things. One is a complete trivia question, which is the canal in the female, if it has a patent processus, is called the canal of Nook, N-U-C-K, rather than the inguinal canal.
Okay.
The other interesting thing is that for females that either develop a communicating hydrocele or an inguinal hernia, they don't close their processus vaginalis, 1% will have a disorder of sexual development. So that'll
1%?
1%. So we're always a little paranoid about that when we're seeing female hernias. Yeah. And so that's just, I think, one to keep in mind. And I mean, I think the first thing is if a girl has a hernia, make sure the perineum appears normal, the urethra and vagina look separate, and all the no virilization and things like that. So
we could maybe say one of the themes of our conversations this month has been, well, we're very thankful for ultrasound. There are times when maybe that's not the first thing to reach for.
I think that's right. Yeah. I mean, clearly you're not doing a bad thing by getting an ultrasound, but it may not be the most cost-effective way to work through it.
Perfect. All right. Question number 3. This is kind of a sort of a fundamental question, I think related probably to our third week's conversation. So what's the current thinking on the best way to get a urine specimen from an infant boy?
So circumcised and non-circumcised is different. So if you're getting a urine, I would say in a really low risk child for UTI, and I presume that's basically what we're talking about. Is there a UTI? Is there not a UTI?
Right.
If the child's not febrile, not sick, if it's some minor thing, a smell of the urine that somebody was worried about, something like that, it is acceptable to place a bag, catch a sample, dipstick and see what the suspicion is. That is a practical answer and maybe not a great book answer according to some people, but I think it's very practical. If that urine is completely clear, nitrite negative, leukocyte esterase negative, then the likelihood you're dealing with a clinically significant UTI is really low. And obviously the benefit is you haven't had to cath them. If it's a sick child, then cathing is the standard. Pretty easy in a circumcised boy, can be more challenging in an uncircumcised boy. I think the key with an uncircumcised boy, the younger they are, usually the smaller the preputial aperture, and often you can't see the glands at all. I think the key things are making sure you get a little betadine in an uncircumcised boy that goes in the preputial aperture so that sort of drifts inside the foreskin and eliminates as many external bacteria from your sample as possible. And then it's usually getting a small, like 5 French feeding tube and just trying to trap the glands as you place the tube through the opening in the foreskin, just lined up as much as you can with your expectation of where the meatus is. And generally, you'll be able to get it in the meatus with a few tries there, but you'll probably go into the preputial sac a little bit. So having betadine in there to eliminate those bacteria, I think is critical to getting the most appropriate sample from those kids. It's been really unusual circumstance when we've done an SP stick in the last 10 years. You know, a sick suprapubic stick, suprapubic tap. We've done it a couple times, maybe in the NICU with a kid who is really complex and a tiny urethra and a 2,000-gram septic kid, you know, and we've almost always done it under ultrasound guidance in that circumstance, Paul. So I think that has become vanishingly less common overall.
It feels like, though, that there has been some swing over history in recommendations. It certainly seems like that suprapubic taps are a little more fraught generally.
I think that's correct. The hard thing is doing it without an ultrasound. You don't know how full the bladder is, and that's a challenging thing. So it may need it occasionally, but I think it's relatively rare.
Perfect. Question number 4 is a little wide open. So when should I consider a workup for hydronephrosis in an older child? The symptoms seem so vague sometimes. For instance, if someone has a change in urination patterns, when do I need to suspect that there's a urinary tract anomaly?
Yeah, I think that's fair, right? And hard. So directly answering in terms of change in bladder habits, the only one that I think warrants really looking at the upper urinary tract, there are a bunch of them that might warrant looking at bladder and seeing what bladder emptying is like, and if, you know, there's debris in the bladder or thickening in the bladder wall. If a patient develops a lot of hesitancy or straining with urination, one of the first things we would do is ultrasound bladder pre and post void and look at the upper tracts to see if there's been like long-standing increased intravesical pressure that's causing hydronephrosis. So that one, in terms of avoiding symptoms, would lead me towards getting ultrasound of bladder and kidneys. The other sort of abdominal pain or flank pain is probably the other thing that comes in, right? Definitely there's a condition of intermittent UPJ obstruction. The pain associated with it has been termed a Deitl's crisis, DEITL''S. And basically that is a patient who gets intermittent blockage at the uteropelvic junction based on unusual anatomy. It can be crossing vessels to the lower pole of the kidney from the cava and aorta, and the ureter drapes over it. And if the kidney shifts position or gets overly full, it acutely worsens drainage through that area, and they get horrible flank pain. So that's a very characteristic pattern, but I think it's under-recognized and hard to pull out of the hat when things are happening. What those patients get is distinct flank pain like they were passing a stone. Obviously, it happens for a first time at some point, but most of them say it's happened 2 or 3 times. Some of them I've seen it's happened 24 times, right, over 3 years. Bad flank pain. Yes, it's rough. A lot of nausea with it usually. They have to lay down, not do anything. It's like down kind of bad pain. And then it resolves spontaneously. Basically, they get volume depleted. The lymphatics in the renal pelvis absorb some of the fluid. The pelvis gets smaller. It unkinks, and the next morning they're ready to go to school. That's an intermittent UPJ obstruction. That one is interesting in that You can do an ultrasound and look for hydronephrosis, but when they're not having pain, sometimes it'll be only a trace and not very impressive. And the key will be getting an ultrasound during a pain episode. So that's how we usually nail that diagnosis down. Sometimes the description is so good that you know what it's going to be. Those clearly deserve an ultrasound. And then for the hardest, most vague patient, I would say that if their pain is sometimes back or flank and persistent enough over time, no matter what the pattern, they're probably going to warrant a renal and bladder ultrasound just to look at basic anatomy and say, that's not it. Let's work on functional bowel and some of the other things that are very common, but a number of them need rule out with an ultrasound just to be sure before we spend 6 months, going down a big behavioral therapy path,
Right.
that we know we didn't miss something critical. There's
Sure.
one of my profs at CHOP when I was a fellow, which is a funny story, told me about a patient with abdominal pain that he knew had a psych problem, sent him to psychiatry, and psychiatry got an ultrasound and sent him back and said it's a UPJ obstruction. He was great.
So you could either get an ultrasound or have the psychiatrist order the ultrasound.
There's 2 ways to go down the pathway. If it's a smart psychiatrist, they'll get you to the right place no matter what.
Yeah. Yep. That's what they do. All right, Pat. Well, thank you so much. Anything else you think we should have talked about?
I think we got it.
It's always a treat talking to you. I really, really appreciate your time.
Thank you for having me on. Appreciate you guys doing this.
All right. For the listeners out there, make sure and tell your friends and neighbors about us if you're enjoying this. That's the only way people find us, and we'll talk to you next week. Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design and editing thanks to Phil Wirkus, who also composed the theme music. See you next time.